which was very which was very prolonged and malignant, I would say, because it was resistant to all standard therapies, and we had to innovate all the experimental therapies and adjunctive therapies to bring the clinical condition under control. So, Dr. Sushil will discuss the case course. We will be focusing primarily on the part of CNS infection. Though the other course was very vast, we will not be touching into it. Over to you, Dr. Sushil.
Thank you, sir. Thank you so much for the introduction, sir. Dr. Vinay Kulkarni, sir, is our senior consultant and head of the department. So today we'll be discussing an interesting case of neonatal meningitis. I hope my presentation is clear, sir. I hope my presentation is clear.
Yes, yes. Yes, yes, go ahead.
Okay. So our index case, we would name it as a twin one. It's a male baby born on 14th of November at referral hospital. Gestation wise, it is 31 days and 2 days, 31 weeks and 2 days old. Birth weight is 840 grams, conceived spontaneously. Uh, coming to the Coming to the obstetric history, the mother is a 30-year-old mother, and it's a twin gestation conceived spontaneously, gravida 3, para 1, 1 abortion, and 1 living child, which is healthy. And our importance in the obstetric history is that mother is a known case of pregnancy-induced hypertension. She is on two antihypertensives, labetalol and nicardipine, and one fibrinolytic, that is aspirin. Initial scans they've done, the NT scan and the TFA scan done were normal. As the uh, as the pregnancy progressed, there was abnormalities in the scans noted. At 29 weeks of life, there is abnormal Doppler in the umbilical artery, which then progressed to reversal of end diastolic flow in the umbilical artery. This has led to the development of oligohydramnios by 31 weeks of life. So with the abnormal Dopplers in mind, so what we would expecting is that according to the criteria, whether it is an early FGR or a late FGR, there will be few clinical changes happening because of the abnormal Dopplers. Initially, there will be uteroplacental malperfusion leading to uterine artery resistance, that this occurs due to abnormal villi formation in the placenta. If that is not addressed properly or treated properly, that would lead to umbilical fetal malperfusions. These can be classified into three things. One is preclinical phase, clinical phase, and decompensation phase. In preclinical phase, majority of it is the blood supply in the venous system will be redistributed. This will be leading to decrease in the abdomen circumference of the fetus. If that is not treated or addressed properly, it will lead to arterial redistribution, that is blood supply being cut off from the arterial side, leading to decrease in the head circumference in the fetus. The next stage would be the decompensation phase. There will be development of excess of metabolic acidosis and finally leading to cardiovascular failure. So with these abnormal Dopplers in mind, we were expecting these changes to be present in the fetus, and we were ready for that. So whenever there is a fetal hypoxemia, there are two kinds of changes in the fetus. One is systemic response, and other one is the cerebral response. In the systemic response, the carotid chemoreceptors are activated, and the stimulation of the parasympathetic system leads to bradycardia, which is cardioproductive, and the stimulation of the sympathetic system leads to significant vasoconstriction, leading to increased blood supply. This increased blood supply is diverted towards the brain because there will be cerebral vasodilatation, and the metabolic phenomena is that there will be decrease in the neuronal activation. This leads to arrest in the neuronal growth and decrease in the oxygen substrate demand as well. So with these two Dopplers in mind, we expect that baby having a insult in the brain as well as in the lungs. In view of these abnormal Doppler changes, baby was delivered by emergency cesarean section. And post delivery, baby cried immediately after birth. Apgars were given 6 and 8. In view of significant respiratory distress, baby was started on delivery room CPAP support, and baby was managed at the referral hospital for 2 days and referred for the further management and care. On arrival to our hospital, the vitals were stable. There were no episodes of any hypothermia noted. This slide is of importance because here we are trying to compare the index twin with the other twin, which is the control twin. Here we can see there is a significant difference in the weight, which is 31% difference between the our interested case of index twin and the other control twin, and the length there is a little less difference of 11%. Here we can see the head circumference is only reduced by 7%, which shows that there is a brain sparing effect here. On systemic examination was quite normal. There is Coming to the provisional diagnosis, our index case is a case of very preterm dichorionic diamniotic twin 1 with abnormal Dopplers, that is reversal of end diastolic flow in the uterine artery with 31% of weight discordance, extreme low birth weight baby. In view of abnormal Dopplers delivered by emergency section, it's a male baby, SGA, symmetrical IUGR with significant respiratory distress. And baby was managed at the NICE hospital from day 3 onwards. On arrival at the hospital, the vitals were stable, and we have quantified the respiratory distress with Silverman Anderson score. The score was coming to 4 by 10, in view of which baby was started on respiratory support, which is the CPAP support. And our hospital protocol is that any high risk infant, if it is less than 28 weeks or less than 1,000 grams, we would generally do newborn screening newborn screening in the form of neurosonogram. When we have done the neurosonogram, we have seen that there are diffuse periventricular white matter echogenicities in our index case. So these are the bilateral periventricular echogenicities which can be seen at the parieto-frontal region. Initially, they were called as periventricular leukomalacia, but because it's an histological finding, right now the nomenclature has been changed to white matter injuries. So these are significant parieto-frontal white matter injuries we can see in our index case. As the course continued, baby had a significant worsening of the hemodynamics, and in view of clinical worsening, sepsis was suspected. And when we have sent the sepsis screen, we have seen that the CRPs were quite high. It is 190, and platelets, severe thrombocytopenia we have noted. In view of which, we have sent cultures and upgraded our antibiotic support. As there were significant changes in the hemodynamics, the respiratory support was escalated, and baby was started on invasive mode of ventilation. On day 8 of life, baby had one episode of pulmonary hemorrhage, for which baby was managed with vitamin K and platelet transfusion, along with Tranexa and Botrofos was given. And the support was continued on invasive mode of ventilation. As we have a positive blood culture showing it as a Klebsiella pneumonia, we want to rule out meningitis. So our first lumbar puncture was done on the day 8 of life. Here are on the screen are the lumbar puncture CSF analysis. It was first done on 22nd of November. Here you can see the counts are quite high. The counts are 4,260. Proteins are quite elevated, and glucose is 12. The color is pale yellow. PCR we have not sent because we have a culture positive sepsis here. It's a Klebsiella pneumonia, and there were no RBCs. Sorry. So the second lumbar puncture analysis, CSF analysis, was repeated after 1 week of giving sensitive IV antibiotics. Here we can see the counts are still high. These are 410. The proteins are still elevated, 460, and glucose being significantly low. And when we have done the in the CSF, along with the CSF analysis, we have seen that a lot of abnormal cells have been seen. They are macrophages and pia-arachnoid mesothelial cells, which are misnomer cells. If histopathology would have been done on this, we would have seen the tissue strands We would have seen the tissue strands consisting of gliotic necrotic cells, macrophages. These are the cells that are seen along the lining of the ventricular walls. So this is the information we are getting from the CSF analysis. Coming Along with the CSF analysis, there are few adjectives that can help us to come to a diagnosis whether it is a bacterial meningitis or a viral meningitis. These are oligoclonal immunoglobulin G and M bands, CSF lactate, procalcitonin, and lysozyme. If these are elevated, the studies are showing good sensitivity and specificity. Sensitivity of 93% and a specificity of 96%, leading towards the bacterial meningitis. And fungal meningitis can also be found out if there is elevated CSF beta D glucan and galactomannan in the nucleic acid amplification test. Coming to the advancement in the diagnosis, most of the time we'll be getting cases which are partially treated. So it's quite difficult to prove meningitis in partially treated cases, as they've started on 1 or 2 doses of antibiotics. In such scenarios, next generation sequencing, which detects the 16S RNA, PCR studies, and this will definitely help in finding out even the minute levels of the bacteria. So the PCR analysis on the next generation sequencing will help in diagnosing meningitis in partially treated cases. Coming to our neurosonogram findings, so as I have told you, our unit protocol is to do initial neurosonogram at the time of admission, followed by day 3, day 7, day 14, and follow up the case. This was one of our neurosonogram we have done on day 7. Here is a video. Here we can see that there is liquefaction and moth-eaten appearance, which can be seen outside the lateral ventricles, and that is involving into the lateral ventricle. And here is another case. Uh, as you can see, the ventricles are quite dilated, and the ventricle wall is thickened, and you can see different kind of septa formation inside the ventricles. This is not generally not seen in cases of meningitis, but this definitely has a prognostication role. So there are two types of septa that can be formed in cases of ventriculitis or periventricular leukomalacia. If the septa are forming from the outside and then they're coalescing into the lateral ventricle, those are called the pseudosepta. If the septa are forming inside the ventricle, then they are called the true septa. The formation of the true septa and pseudosepta helps in the prognosis and management of the case. This is another case where we can see there are septa formation. This is the debris as we have seen in the histology. And here in all these cases we can see there is a ventricle wall which is quite thickened, and the septa is forming inside the ventricle, which is a true septa. So this is the neurosonogram we have done in the index case by day 10 of life. This is the coronal view. We can see the moth-eaten appearance and the pseudosepta formation above the ventricle. So this is a parasagittal view. Here we can see the moth-eaten appearance, and this pseudosepta are coalescing and forming a big coalescing into the lateral ventricle. This is our index case. Here is how the pseudosepta formation has happened, and it is coalescing into our lateral ventricle, and there is dilated third ventricle as well. Eventually, with the small septa, it coalesced into the lateral ventricle, formed a big ventricle, and there is formation of the true septa inside the ventricle. There is some interesting maneuver here because of all the increase in the ventricular debris. When we are doing the neurosonogram in the parasagittal view, the debris will be settled down. When the head is tilted towards the other side, we can see there is quite a significant increase in the debris. So through all the previous slides, we have seen the pathological evolution of ventriculitis. There is initially increased ventricular thickness, followed by irregularity and ependymal echogenicity. Then we have seen how the debris get settled down in the ventricular cavities. With all this, there will be septal formation by the exudates, and the intraventricular cyst will be late in the infection. This can be seen as soon as day 17 of life. So we have done the CSF analysis. Then we have serial neurosonogram findings. All this leading to the suspicion that the meningitis has evolved into the ventriculitis. With all the suspicion, because there was no clinical improvement, no cytological improvement in the CSF analysis, and neurosonographically also there is increased thickness of the lateral ventricles and formation of pseudosepta, we suspected that there is ventriculitis, and we went ahead with the ventricular tap. So this is our ventricular tap procedure. So here with we would be looking at the landmarks, and we would be looking at the lateral border of the lateral ventricle, and the needle will be inserted on the ipsilateral side of the medial canthus. The thing of importance here is that the free flow of the CSF. This is how we have routinely done our ventricular taps for this index case. Once we have done the ventricular tap, the ventricular tap CSF analysis was showing counts were still elevated. They are 180, proteins are high, 440, and glucose is significantly low. The color is pale yellow. There were no RBCs. So with this, we have confirmed it as ventriculitis along with the neurosonogram and the CSF analysis. Coming to the definition of ventriculitis is nothing but a ventricular inflammation with infection, and it is suspected if there is persistence of infection in the CSF analysis in spite of treating with adequate sensitive antibiotics. In few cohort studies in Canada, they have seen that the rate of ventriculitis is as high as 6.3%. If there is underlying proven bacterial meningitis, it increases to 20%. And if there is germinal matrix hemorrhage or intraventricular hemorrhage, there is significant increase in the amount of ventriculitis. The point to be noted here is that if there is gram-negative bacterial meningitis, like in our case, the ventriculitis rate increased as high as 52 to 94%. Coming to the diagnosis of ventriculitis, it always a dilemma as there is no clear-cut guidelines and current recommendations for diagnosis of ventriculitis. It always depends upon the suspicion and also the expert's opinion. As the clinical signs of infection and fever are very subtle in a neonate, and they're much more difficult to elicit in a preterm infant. Coming to the factors favoring ventriculitis, the newborn itself is more favorable for formation of ventriculitis because of the glycogen-rich choroid plexus and very immature immunity. And if there is underlying sepsis, the rate of ventriculitis increases by 25%. Ventriculitis, there can be inflammation of the ventricles, ventricular fluid, and the surrounding tissue, and these frequently develops because of the meningitis, leading to the obstruction of the normal CSF flow. And the infectious pathogen can enter either through the bloodstream or through a foreign body like the through the shunt device. Coming to the etiology is same as an early onset or late onset sepsis, which includes group B streptococci and mostly the gram-negative bacilli like E. coli, Klebsiella, or Listeria. Staphylococci are more common if there is a CSF drainage device or VP shunt. And over the last few decades, what we have seen is that there increase in multi-drug resistant pathogens from 41% to 58%. There is a significant amount of antimicrobial resistance. Most of them are gram-negative bacteria. If it is an Acinetobacter baumannii, the resistance have increased from 4% to 11.2% in the managed cases with ventriculoperitoneal shunts. And carbapenem resistance has been 43% in the Mediterranean countries and 62.4% in the Southeast Asian regions. And even the colistin resistance has been high, almost till 10%. Coming to the guidelines for the diagnosis of ventriculitis, according to American Infectious Disease Society, if there is on CSF analysis, if there is elevated protein count more than 50, low glucose levels less than 10 out of the cells, if there are more than 50% neutrophils, gram stain or culture positive, it is diagnosed as ventriculitis. Once there is diagnosis of ventriculitis, so this slide shows the serial lumbar punctures and the ventricular taps we have done. The initial lumbar puncture was done where we can see the cells were quite high, 4,620, and proteins are elevated, 397. Sugars were quite low, 12. After 1 week of giving sensitive antibiotics, still the cells were high. With our neurosonogram and the repeat CSF analysis, we got convinced that the meningitis is leading towards the ventriculitis. We have done the ventricular tap. The ventricular tap was showing increased cell count in spite of the treatment. So here is a graph showing the days of treatment, the CSF cell count, and how the CSF protein progressed and then improved with the course of the treatment. Initially, the CSF cell count was high and it increased almost to 680. As with the course of intraventricular treatment, it reduced to 20, which is the latest value. Initially, the CSF protein count has also been elevated. This we would admit to the intraventricular antibiotic. Sometimes the antibiotic itself can cause chemical ventriculitis. With the serial treatment, there is quite an improvement in the protein content as well, the latest being 396. Coming to the final diagnosis, our index case is a very preterm dichorionic diamniotic twin 1 with 35% discordance, SGA symmetrical IUGR, with significant respiratory distress and pulmonary hemorrhage. Baby had septic shock with myocardial dysfunction, symptomatic hypoglycemia with significant thrombocytopenia, late onset sepsis, which is Klebsiella culture positive, meningitis leading to ventriculitis, and grade 3 cystic periventricular leukomalacia with intraventricular hemorrhage. Baby also had acute suppurative otitis media, neonatal jaundice, which is managed conservatively. Coming to the management of ventriculitis, we have three modes of management. One is the standard treatment, the newer methods, and the experimental methods. Coming to the standard treatment is conventionally giving prolonged duration of intraventricular antibiotics. The newer methods would be placing a reservoir device and coating it with antimicrobials. The experimental, which we tried in our case, is intraventricular antibiotics. And the last resort would be neuroendoscopic drilling and ventriculostomy. Different modalities of the treatment, you can place a ventricular reservoir device or a ventricular subgaleal shunt, Omayo reservoir endoscopic procedure, or a permanent VP shunt. Coming to the conventional management is to give IV antibiotics for a duration of 4 to 6 weeks. The only drawback is that there is a weak penetration into the blood-brain barrier as the CSF flow is always obstructed by the debris and the proteins. Coming to the intraventricular therapy can be given by either through direct installation with the like we have done in this case, or a reservoir device can be placed and the antibiotic can be delivered with the reservoir device. The drug of choice depends on the nature and susceptibility of the pathogen. Many antibiotics have been tried, like the aminoglycosides, polymyxins, antifungals like amphotericin B and caspofungin has also been tried. Coming to the guidelines of Infectious Disease Society of America, they have seen that the Since the last positive culture, the antibiotic, intraventricular antibiotic should be given for a duration of at least 10 to 14 days. There were only few case series and case reports documented. In 2018, they have tried the first intraventricular delivery of tigecycline in an 8-month-old infant infected with extreme drug-resistant Klebsiella species. And in 2019, they have tried in a vancomycin-resisted Enterobacterium faecalis in a 5-month-old infant. In 2020, they have tried in a 2-month-old with a multi-drug resistant Acinetobacter baumannii species. Coming to the Indian studies, Kumar et al. Had published a case series in which he has noted that the minimum duration would be around 9.1 days and the duration can be increased if the reservoir device is infected. And coming to the different studies, why would have why the how we have chosen colistin? The CSF penetration is very poor in spite of the meninges being inflamed. And few studies have shown that in the CSF colistin penetration is as low as 5%. And these studies have shown that to achieve a significant level, the systemic dose has to be given very high, which will lead to significant side effects. Hence, we have chosen colistin intraventricular therapy. Our adaptation here is that we have to give intravenous antibiotics for 6 weeks. We would do the serial ventricular taps, and every time we do a tap, we would drain at least 10 to 15 ml per kg of CSF, and twice weekly intraventricular colistin administration, and we would see the serial or OFC monitoring. Coming to our index case, what makes this baby very susceptible is that baby being very premature and antenatally their abnormal Dopplers leading to FIRS and leading to periventricular leukomalacia and the significant amount of bacterial load and gram-negative organism being the very difficult to treat with the intravenous antibiotics and ventricle being a very safe haven as it is protected and the intravenous antibiotics are very difficult to penetrate the CSF. So here is the graph showing the serial head circumference. When baby was born, the head circumference was 24 centimeters. Over a period of 2 months, it has increased to 34 centimeters. Coming to the other morbidity and the prognosis, if there is ventriculitis, there is significant amount of morbidity with mortality being almost 33% and developmental delay, cerebral palsy, hydrocephalus and seizures, hearing loss and visual impairment can be seen in these cases. Coming to the prognosis, MRI brain will definitely help us in prognostication of the case. The in MRI brain, the significant finding we would see is the ventricular debris. Ventricular debris is hyperintense on the T1 weighted image and hypointense in the T2 weighted image. So here is an MRI of our index case. So this is the ventricular debris. This is T1 weighted image. The CSF is black here. So we can see the ventricular debris, which is hyperintense. This is the T2 weighted image. Here we can see the ventricles are increased in size. This tells us that the white matter injury has been significant. And at the same time, we can see the debris, which is hypointense. Coming to the other modalities of treatment, the next modality of the treatment is surgical intervention. The surgical intervention depends upon whether they are true septa or the false septa. So, many studies have shown that endoscopic third ventriculostomy is much superior to ventriculoperitoneal shunt in terms of the reoperation and complication on the subsequent days, like day 4, 12th, and 24th. And the latest research shows that it's a RCT, which is called Basics RCT trial, which has shown quite a good evidence that any device, ventriculoperitoneal shunt coated with an antibiotic significantly decreases the biofilm formation. What they have seen is that there 50% reduction or inhibition in the biofilm formation with E. coli, Staph aureus, Candida albicans after 72 hours of life. And the other point that that need to be noted is that any intervention that accesses the central nervous system or the ventricles increases the rate of infection by 10.7%. And a study by Hydrocephalus Clinical Research Network, they have reported that infection rates can be as high as 14 to 17% if there is subgaleal shunting or a reservoir device. Coming to the quick summary of the case discussed here, we have seen what all can predispose to a white matter injury: antenatally abnormal Dopplers, venous and arterial redistribution leading to significant white matter injury. On top of that, we had an infection, CNS infection leading to meningitis, and meningitis leading to ventriculitis. And here we can see when to suspect ventriculitis: when there is no significant clinical improvement and there is no significant cytological improvement. That is when we have to suspect ventriculitis. And the ventriculitis can be monitored by doing serial ventricular taps, doing CSF analysis, and with followed up with the neurosonogram findings. Coming to the management, here intravenous sensitive antibiotics and intraventricular treatment will be the treatment of choice, as even though the meninges are quite inflamed, the penetration of the susceptible antibiotic into the through the blood-brain barrier is not significant. And also, when there is a significant increase in the head circumference, as we were following up in the case, and true septa or the pseudo septa formation, then the last resort would be doing neuroendoscopic drilling and ventriculostomy. Coming to the take home message is that early FGRs are more predisposed for white matter injuries, and the liquefaction of the periventricular white matter and the cyst formation can be seen as early as day 17 of life. And serial lumbar punctures or ventricular taps are the minimally invasive procedures to reduce the progressive ventricular dilatation and for prognostication and management. Serial neurosonogram to assess the septa and pseudosepta formation will help in the further management of the hydrocephalus. Thank you.
Well, thank you very much, Dr. Sushil. It was a lucid and clear presentation. Few points which were pointed out in your presentation, I want to emphasize them once again. One is the ventricle is the safe haven for any antibiotic, anti sorry, a ventricle is a safe haven for any microbes. So in the neonatal ventricle, if any microbe gains entry, it is protected from the systemic antimicrobial therapy to a great extent. So there they tend to form colonies and a capsule around them, and then they are prevented from being destroyed by the systemic antimicrobial therapy. So that's why we have to give a prolonged treatment for this, and the prognosis is little worse as compared to only meningitis. That is one point which we need to remember. And when to suspect and how to progress, how to approach a case of ventriculitis, we have discussed in detail in this presentation. Option was to put a reservoir in this case, but baby being 800 gram, nobody would prefer to undergo such a procedure. So serial intraventricular therapy was actually planned and conducted, and we could successfully treat the ventriculitis in this case, as evidenced by the reduction in the cell count. Last is that intraventricular therapy is used widely in many of the institutes, especially in the tertiary care neonatal units, but not so published. We find very less literature on the use of antimicrobials given directly inside the ventricle, especially when a device is not there. Like the way we did in this case, we every time we used to tap, and we used to use a fresh 24 gauge cannula, and then we used to follow the procedure under aseptic precautions and instill the antibiotic and then come out. So this procedure is very rarely used. If you place a reservoir, we can actually go through the subcutaneous plane and administer the antibiotic. So, but for such small babies, placement of such a reservoir and risk of associated dermatitis and the skin infection progressing inside the ventricle would be an added morbidity, and we may sometimes lose the baby in such cases. So, these are the three things which I wanted to highlight in this case at the end of presentation. Few of the points discussed in the chart. duration of antibiotics in meningitis, should we have to do a repeat CSF? Repeat CSF is not indicated in all meningitis cases to document normalization of the parameters, but sometimes the organism is like, staphylococcus aureus, or if the neonate is very premature like ELBW, wherein sonologically you keep following and you are seeing not a normal brain, then a definite repeat CSF, as in this case, is indicated. So if the repeat CSF does not show sterilization or resolution of normal, which we call as clearance of CSF, then definitely we have to suspect ventriculitis in this case. Next question is, for drugs like vancomycin, through intraventricular drug, should we give directly or via infusion? Actually, infusion therapy is not feasible in intraventricular route, because you may either be giving it through the reservoir or by direct injection. Slow infusion, at the max you can go give it up to 2 to 3 minutes. Luckily, when the drug is deposited inside the ventricle, you have already removed enough of CSF to give a space accommodation for this drug volume. And reactions don't happen if you are doing it under controlled conditions. And dose for intraventricular injection, well, different drugs as per the literature have been quoted, and different doses are being given. For colistin, we followed same as intravenous dose. In fact, in this case, we did not use intravenous injection of colistin at all. We used intravenous meropenem in combination with intraventricular colistin at the dose of 25,000 international units per kg per dose. Any How to differentiate pseudosepta from true septa has already been discussed. Tranexamic acid in this case was used for stopping bleed from the pulmonary area, because it was a life-threatening pulmonary hemorrhage, and we had to use it as a last resort. Though the evidence is not grade 1 evidence in favor of tranexamic acid. And repeat LP, I have already discussed under which condition you have to actually go for. The one question is, how much time you took to give intraventricular colistin injection twice weekly? Is it enough? So twice weekly was chosen a customized way for this case because of the availability of the CSF access. Because initially the ventricle, as shown, was very small. Later on, it gradually enlarged. So if you do taps repeatedly, it's not feasible for a ELBW, and you may cause side effects, or even increase in hemorrhage risk is there. So twice weekly was chosen for that reason. And we could successfully clear the ventricular infection after 7 to 8 weeks of therapy. After 6 weeks of therapy, we stopped intravenous injections, but we continued intraventricular injections, and now the CSF is totally clear. And CSF sugars, actually, CSF sugar is the last parameter to get normalized, and hence it will take a little more time. We are waiting for complete normalization.
Yes, sir.
Was Klebsiella also grown on CSF culture? No, in this the CSF culture was sterile, ventricular CSF, because it was already 7 days when we did the first ventricular tap. LP CSF yielded a lot of cells, but the culture was sterile even in that. It was done after 2 days of sensitive antimicrobial therapy.
Yes, one more question, sir.
Yes, which one you
The
can answer?
periventricular echogenicities at day 3 in index case, can it be related to infection?
It can be or cannot be also, but the morphology which we saw, I think it was not clearly evident on the video we showed you, but it was morphologically a periventricular leukomalacia rather than the infection part. The infection actually started uh, a little later, we can say by around 48 hours, and the liquefaction happened subsequently. We could clearly make out two distinct areas of brain damage by two distinct etiology. One was the PVL, which was going on with echogenicity progressing to liquefaction. The other area was the ventricle. Inside the ventricle, there was a debris formation, fibrin strand formation, which you call a septa, pseudosepta, all that thing. There is another question. Was it given TID? No, intraventricular cholesterol cannot be given TID because in a day you cannot tap the ventricle 3 times. It's a very dangerous procedure. So only once on that particular day it was tapped. So all the 3 doses can be given combined at one time because it's a local drug. The ventricle, inside the ventricle, when you increase the level of cholesterol, they are not absorbed into the systemic circulation as well. The reverse is also true. When we say we are giving intravenous cholesterol, it is not reaching CSF. When it reaches CSF, it will not reach the bloodstream. So chances of side effects are low. We even monitored renal functions. It was not affected. So the 3 dose combined was given at one point. So it would be 75 units, 75,000 units per kg per day as a single shot inside the ventricle. So today I'm seeing a lot of queries and responses, which means the case was really interesting. So your responses and curiosities have made our day. And I
Sir,
hope we
hello.
have given a very good message to the audience that whatever we do not publish it always. But sometimes we have to customize the therapy for an individual baby and somehow bring the baby out of the problem.
Sir, good evening, sir. Hello.
Yes, please.
Sir, intraventrically, how slowly you given a cholesterol, sir? Over 5 minutes or
Over
10
a
minutes?
period of 1 minute. Over a period of 1 minute, our volume was around 0.8 ml. So we kept the timer and slowly injected. Only one precaution, extra precaution we have to take is there should not be even a speck of air bubble when giving the antibiotic because it may cause pneumocephalus. Because sometimes intravenous we are little casual about air bubbles, very small air bubbles we don't remove. But in intraventricular we have to be very strict about air bubbles when injecting the drug.
Okay, thank you, sir.
Okay.
Sir.
So if there are no more queries, I think we can call it a day. Sushil, you have anything else to say?
Yes, sir. That's it, sir.
Okay. Okay then. Thank you.
Thank you. Thank you
Thank
so
you
much.
all for joining and enjoying the session. We'll meet sometime very soon.
Thank you, sir. Thank you so much.
Okay.